In Chapter 3, we're going to discuss immunity in a general sense and immunologic conditions that we see in the oral cavity. This chapter is full of things that you may see on your national board exam, so you really want to take time to take good notes and pay attention for those board alerts because there are quite a few of them in this lecture. In Chapter 2, we discuss the inflammatory response, which is our body's first line of defense against a pathogen. And our immune system is our second line of defense. So the inflammatory response occurs when tissues are injured, like with bacteria or trauma or toxins or heat. And the immune response protects the body from harmful substances by recognizing and responding to antigens which are present on the surface of that foreign substance. So our bodies create a memory every time it encounters a foreign substance, ideally, so that the next time it encounters that substance, it can kill it more efficiently and more quickly before any symptoms arise. There are 3 types of lymphocytes, and you're going to want to know all 3 of these. The first one is a B cell lymphocyte. This begins in the bone marrow. The T cell lymphocytes also begin in the bone marrow, but they mature in the thymus. And then we have natural killer cells, and these also begin in the bone marrow. So as you can see, our bone marrow is essential in the fight against disease because these are the guys that are going to help protect us from foreign invaders. So if you have a problem with your bone marrow, then you're in deep trouble. The immune response, there are 2 different types of immune response. There's cell-mediated and humoral. We're going to talk about both. Antibodies are what our bodies used to recognize and attack foreign substances. So think of antibodies like your computer's antivirus. They recognize a foreign website, a foreign substance, they engage with that substance, and then they attempt to eliminate that substance. I'm going to simplify this process a lot and try to break it down into what you really need to know. So when it comes time for your first exam, you're going to want to pay attention to what I focused on in this lecture in order to be successful, because there's a lot of information in your text, and not that it's not good information, but some of it is unnecessary for you. So I'm going to try to break all of this down for you in a way that you can understand. So please focus on what we're talking about in this lecture for your exam. The B cells become plasma cells. The plasma cells copy a protein, the antibody, from the memory formed by the B cell. There are 5 types of antibodies produced by plasma cells, and these are called immunoglobulins. Each of those immunoglobulins work to target a specific antigen. So here is your first board alert. You need to know your immunoglobulins. They are very likely to ask you something about the individual immunoglobulins. Let me try to give this to you in a visual. Okay, now just a disclaimer. I shouldn't have to tell you guys by this point, I can't draw. And I'm doing this on my laptop screen, so forgive me. First, we have a B cell, and that turns into a plasma cell. And then suddenly an invader appears, which we have here, and that plasma cell is going to, from the memory of the B cell, start to create copies of that antibody because that B cell remembers this invader from before. So it's just going to keep duplicating that antibody that will attack that cell. And then they're going to invade, and kill that cell. That's pretty much the basic concept. The first immunoglobulin produced by plasma cells is the IgA. This is the one that we would find in our saliva. So this is going to defend against microorganisms found in the bodily fluid. And then we have IgD. These are found on the surface of B cells, and they're a little bit mysterious. We don't know as much about the IgD as we do the other ones. IgE are involved in hypersensitivity and allergic responses. You're going to want to know this one. IgE are involved in hypersensitivity and allergic responses. These guys bind to mast cells and basophils and release biochemical mediators like histamine, which then increase the permeability of the capillaries to the white blood cells and the proteins and allow them to engage in battle with the pathogens. In my previous video, I broke down the inflammatory process to injury. So instead of a pencil injury to the skin, think of a mosquito bite. The inflammatory process is the same, but there's an IgE response to the substances produced by the mosquito, and that histamine response leads to swelling and itching, but it allows for our body's defense mechanism to attack that foreign substance and protect us. IgG are the most abundant antibodies, but they are the smallest, and that allows them to cross through smaller barriers like the placental barrier. So this is the one that creates passive immunity from a mother to a newborn. We're going to talk more about passive immunity in just a little bit. These guys are opsonizers, so they coat the surface of the substance, which signals the white blood cells that they need to come and destroy that substance. IgM are the largest, and they stay mostly in the bloodstream because they are the largest. Their large size gives them excellent binding ability, and they can pick up trace amounts of infection and mark them for recognition by phagocytes. These are the first to appear during fetal development. So they play an important role against septicemia since they are the ones that are floating around in the bloodstream. The T cells, there are 4 types of T cells which you need to know. The first one is going to be the T helper. This is going to help increase the function of the B cell, and it also helps activate T cytotoxic cells. They're one of the most important components of our immune system because we need all the help we can get, guys. The T suppressor cells tell the B cells when to chill out. They're like, look, you're done, chill out, because we don't want an overreactive immune system that can lead to other problems. So we need some suppressor cells to help those B cells chill. And then we have our T cytotoxic cells, which kill viruses and cancer cells. This might be a little bit scary to think about or realize, but we have cancerous cells in our bodies all the time. Our immune systems are very efficient at destroying those cells. So it's really not until our immune system fails to remove those cancerous cells that we end up with a cancerous tumor. So you can thank your T cytotoxic cells and some others for their incredible efficiency in that way. The T memory cells, these help retain the memory of the foreign substances, much like the B cells do, so that next time they appear in our immune system, we can respond quicker and kill them faster. Sorry, I forgot to give you that visual. The natural killer cells are also referred to as NK cells. Look, these guys are just the straight up snipers. They just kill stuff. They don't need any help. They work alone. We want them because they kill viruses and cancer cells before they can invade. Macrophages are accessory cells which help the B and T cells. but unfortunately they don't contain memory, so they have to be reactivated each time. Macrophages don't always participate, but when they do, they are there to help the others. The dendritic cells also enhance the immune response by presenting the antigens to other cells. So they're kind of like saying, hey, come over here, need some help. They're like the messenger system. Cytokines work as another form of messaging. There are different types of cytokines, so you're going to want to review those in your text. There's a table for you to look at, but they basically mediate and regulate immunity. So they like to tell the other cells when they should report for duty. They recruit other cells. The difference between humoral versus cell-mediated immunity. I think I can better explain this one with a video as well. With cell-mediated immunity, first we have the T lymphocytes, which are created from stem cells, and that is what is involved in the cell-mediated response. What does that really mean? Well, first we have a virus, and that virus affects a cell. And along comes some antigens on that cell surface, which signal those T cells to come join the party. They're saying, hey, we found something here in this cell and we need help. And that virus is within that cell. So those T cells come along and they produce cytokines, and those cytokines recruit other cells to come and help. So then we have the cytotoxic T cells and the natural killer cells and maybe some macrophages, and then they basically invade the cell and kill the virus inside that cell, and unfortunately the cell dies with it. With humoral response, we have the B cells, which are also created in the stem cells, and those can become plasma cells. Those do become plasma cells, and they're involved in the humoral response. So what is the difference between cell-mediated response? Remember, with the cell-mediated response, it was intracellular, meaning that virus had already invaded the cell. With the humoral response, it is extracellular. So here we have a little bacteria, and he's just kind of floating out, just trying to find, somebody to attack. And it's still outside of the cell. And so floating around, we have our antibodies, and they go, hey, wait a minute, I recognize you from before. I don't think so. And they just basically kill the guy. So they're going to engulf it, eat it, kill it, and that's that. So that's just a simplification of the difference between cell-mediated response and humoral response. Now this slide we're going to stay on for quite a bit because I have a lot to say about this particular topic. There are two ways in which we can build immunity to foreign substances, passive and active. So think about a newborn baby. They have a little bit of passive immunity from their mom. That is the memory that is transferred from mom to baby, but their immune system is very weak. So they have to be exposed to every foreign substance, every bacteria and virus and every fungus, everything to build immunity to those substances so they can survive. So they are born with passive immunity, but they have to develop their own active immunity. Another type of passive immunity would be by immunotherapy. So this is an emerging treatment in many cancers where they transfer immunity so that the body can more effectively fight those cancerous lesions. And in some cases, this has proven extremely beneficial. I'm definitely not an expert in immunotherapy, but I did want to make sure and mention it in this lecture. Active immunity refers to our own body's production of antibodies against the foreign substance that it has encountered. So this can happen naturally with disease or by inoculation via immunization. So here's where we're going to get into a little bit of a hot topic. Now listen, I'm not going to hold back on my feelings about this one. Vaccines save lives, period. You're going to hear a lot of misinformation, a lot of jargon from people who have absolutely no medical training whatsoever, who are going to try to convince you that vaccines are bad. Now, with anything, there is a risk. When you inject a substance into your body, there are risks. But with vaccines, the positive outcomes far exceed the risk, exponentially exceed the risk. So what does a vaccination do exactly? Well, most vaccines are essentially dead viruses, dead vaccines. That means that the germ is not alive. It cannot cause an active infection despite what anyone with no medical training may have tried to tell you. There are some live vaccines which have been genetically weakened, so they're so weak that they can't produce a illness in the host, but they are highly unlikely to cause an infection unless you are already immunocompromised. Now, when that vaccine is administered, your body doesn't realize that it's not alive and it reacts. And sometimes that means you get redness and you get swelling and you may have fever because your body is doing a really good job of building antibodies to that substance. It's doing exactly what we wanted it to do. The shot did not inoculate you and make you sick. It activated your immune system and allowed it to build memory against that substance in case you encounter that substance again, so your body can recognize and destroy it before it destroys you. So the really cool thing about vaccinations is that they create a herd immunity. It's a massive passive immunity. Because so many people have been vaccinated against the substance, it's highly unlikely to invade a person who has not been vaccinated, like a baby, or a cancer patient who is immunocompromised, or a person with a genetic immune disorder. So the virus is continually killed by the herd, therefore keeping the weak host safe. Now, what we're seeing is a population of people who no longer trust the medical environment. How many of you have believed or known someone who insists that they got the flu every time they were vaccinated? Maybe you believe that about yourself. This is actually medically impossible. I hate to break it to you, it's medically impossible unless you were severely immunocompromised and you received a live virus inoculation. Most flu vaccines are dead viruses. The live ones are done usually through the nose. So if you were injected with a flu vaccine, it was a dead virus. So how did this phenomenon even occur? Well, people do remember adequately getting a fever, feeling tired and achy, and maybe they had some redness and swelling at the injection site, and they associate that vaccine with illness. Or they got a vaccine and it really is kind of a guessing game. There are several different strands of the flu, so they have to produce a vaccine that is the most likely to kill the flu that is predicted to be the dominant flu of that season. And sometimes you get exposed to a flu that was not covered by the flu vaccine. So it wasn't the flu vaccine that caused your flu. It was a different strand of the flu that was not covered. Or it takes time to build that immunity. So maybe you were already inoculated with that flu from someone and then you got the shot. You were already sick and you didn't even know it. And people who believe this really believe it to be true. They don't understand immunity or the vaccination process. And if you can tell I'm getting animated and very passionate about the subject, I am. I happen to be one of those vulnerable immunocompromised patients in a different way. I have severe life-threatening asthma. And that means that sometimes I cannot get the flu vaccine because my system is immunocompromised from the use of corticosteroids. And so I'm really reliant on those around me to take care of themselves and stay well and get vaccinated so that I reduce my chances of getting the flu, because the flu can be deadly for me. So I do get very passionate about that because there's a lot of misinformation out there. It's kind of like in dentistry. You're going to hear a lot of patients say, yeah, that dentist had one knee on my chest trying to take my tooth out. Let me tell you guys, in all my years of dentistry and having witnessed thousands of dental procedures, never ever have I witnessed this phenomenon, nor have I heard of any other dental professional who has witnessed this. Yet I've heard it from hundreds of people that dentists put their knees on their chest when they're trying to take a tooth out. It's a myth that has really grown over time. So if you ever wonder what my thoughts are on vaccination, now you know. If you came into this lecture thinking that you were anti-vaccination, I hope I've helped you see this in a different angle. Education is power. You now understand the process of immunity and how vaccinations help protect us against disease. If I was unconvincing to you and you still don't trust medical science, I promise not to hold it against you. I do hope, though, that one day you'll grow to respect me enough to come to me and say, hey, remember that time you talked to us about vaccines? Can you explain that to me again? And if you do, I'll happily explain it to you again. If the same technology that we enjoyed today existed just 100 years ago, the population would truly be horrified at our current anti-vaccine movement. Horrified. It's easy to forget history when you did not live it. Okay, moving on to hypersensitivity responses. Hypersensitivity simply means allergic response. There are 4 basic types of hypersensitivity that occur. The first one is going to be type 1, and this is going to be a board alert. Type 1 is the most severe. Type 1 is the most severe. It's going to happen almost immediately. When our body encounters an allergen, we release IgE, which binds to the mast cells and releases histamine. So this can cause anaphylaxis, hay fever, asthma, hives, swelling. Then we have type 2, which is a cytotoxic response, and so that's going to include IgE and IgM. Remember that our IgM stay in our blood because they are so large, so we see this response mostly in the blood. An example of this would be Rh incompatibility. If you have Rh negative blood and you receive Rh positive blood transfusion, your blood is going to recognize that blood as a foreign substance and begin attacking the blood cells. That can result in a fatal hemolytic anemia. It is a very serious condition. So when you're pregnant, if you have Rh negative blood and your fetus has Rh positive blood, then they're going to give you some medication to mitigate that factor. Type 3 response happens with autoimmune conditions where the body may mistake normal substances as foreign invaders. So in that case, you're going to get an influx of neutrophils in the area. If you remember in chapter 2, those neutrophils die as a result of phagocytosis, and they release enzymes which are damaging to the surrounding tissues. So that's why autoimmune conditions can just exacerbate themselves, essentially. The last one is going to be type 4. That is a cell-mediated immune response rather than a humoral response. This is the least severe of the 4, and the response is often delayed. To give you an example, if you've ever had your ear break out from wearing a certain type of earring, it was likely the result of a nickel allergy and the type 4 immune response. So don't buy nickel-backed earrings, ladies. Drug hypersensitivity. When you're in the clinic, a lot of patients are going to claim to be allergic to certain drugs or substances. But are they really? What's the difference between a side effect and an allergy? Well, a true allergy means that our body is recognizing that drug as a foreign invading substance, and it reacts with a hypersensitivity response. There could be fever, itching, hives, swelling when we're exposed to that irritant. A side effect means that the patient experiences a known symptom associated with that drug that is not an allergic reaction, such as vomiting, diarrhea. I just feel funny, they'll sometimes say. These are side effects. How will we know if a patient truly has a drug sensitivity or if it's a side effect? Well, we have to ask. Our patients claim to be allergic to something. Let's say they're allergic to penicillin. The first thing you should do is ask, what type of reaction do you get when you take penicillin? If they say, I break out in hives, well, that would signal to me that there's a true allergic response. If they say, it just really upsets my stomach, well, that's not really an allergy, it's a side effect. But the general population does not understand the difference, so they'll often confuse a side effect with an allergy. For us, we need to know, is it a true allergy? If we have a patient who has the propensity towards true allergic responses to things, then we need to know that up front. Or there may be something that is a close member of another drug family, and so we may just avoid that drug altogether if we know the patient has a drug response, an allergic response. How will you document this in the clinic? Well, under allergy, you're going to list the possible allergy, and then you're going to tell us the reaction that the patient described. So that's going to alert all the providers to the true nature of that supposed allergy. In the clinic, you're expected to ask what type of reaction that patient experiences, and we're going to begin questioning you as to whether it's a true allergy or a side effect. Because now you should understand the immune response, and you should be able to recognize if it's truly an allergy. As a side note, though, opioid medications such as Vicodin, Lortab, morphine, those are known to have a side effect of itching, but itching alone is not an allergic response. However, if the patient reports hives in addition to the itching, this would indicate a hypersensitivity. So here is your first submission question. In your own words, describe the difference between an allergy and a side effect and give an example of each. With autoimmunity, we're going to have a failure of our recognition system in our body. It mistakes our own tissues as foreign substances and initiates an immune response. That can happen because of genetics or as a result of a viral infection, and it can affect cells or entire organs. Autoimmune diseases, there are many of them, and they can be quite devastating. With immunodeficiency, we have a compromised immune system, either by disease or genetic condition, and normal immune reactions are suppressed, which leave the host, us, vulnerable to infection and cancer. In Chapter 2, we talked about our concerns over immunosuppression, which now should even be more in focus for you. If we have a patient taking an immunosuppressant medication, he or she is vulnerable to infection. We have turned off their immune system with that immunosuppressant medication. We don't want to stir up bacteria in the mouth, which that patient may or may not be able to defend themselves against. So we'll get a med consult, because sometimes those patients need to take a prophylactic antibiotic before we do anything invasive. In the clinic, we're going to hold you responsible for knowing whether your patient requires a med consult, and the information is right there for you in the clinic manual. So when you contact Ms. Norell or myself and ask if your patient needs a med consult, if it's in the clinic manual, we're likely to say, did you read your clinic manual? Because we can't possibly cover every single condition that would require a med consult, so we have a common conditions guide. And if your patient has a condition that is not listed in the common conditions guide, please reach out to us before the appointment. If your patient shows up to their appointment and has an immunosuppression, or they're taking a drug that's on our red flag list and you didn't catch that, then we're going to question you about how you prepare for your appointment. So remember, we're thinking as providers, not just as students. Here we have another board alert. And I say that, when I say board alert, that doesn't mean that the things I say, here's a board alert, this is going to be on your board. I don't know. But I do know that there are certain conditions that need to be emphasized because you're likely to see them or it's possible. And that doesn't mean that those things I don't say are a board alert are not going to be on your board. I'm just trying to draw your attention that this is something that has more of a chance of being on your board, and that would be aphthous ulcers. The reason being, we see these all the time. Aphthous ulcers are one of the most common reactive lesions that you're going to see, and you're going to see them often. I'm hoping that some of you see them in clinic this semester. They're sometimes called a canker sore or aphthous stomatitis, but we generally refer to them as aphthous ulcers. They tend to be episodic and they result from trauma or stress or a viral infection. We see this a lot in kiddos as well. Minor aphthous ulcers are the most common. There are 3 types: minor, major, and herpetiform. With minor aphthous ulcers, you're going to see a yellow-white fibrin center with an erythematous halo. They may have a punched out appearance, and they're more common in the anterior. You'll see them commonly on the lips and the buccal mucosa, in the vestibule. They're pretty painful, so it may inhibit your ability to provide treatment. And it takes about 7 to 10 days to heal. So if you see an aphthous ulcer on your patient, you want to try to avoid touching or stretching that area as much as possible because it is very painful and you can just cause more inflammation. Major aphthous ulcers are also called Sutton disease, and those are going to be larger than 1 centimeter, and they appear the same as minor aphthous ulcers, but they're usually going to be in the posterior of the mouth, and they last longer. They can take weeks to heal, and they can actually lead to scarring. Herpetiform ulcers are the smallest, and they're also the least common. They get their name because the appearance can resemble a herpes simplex outbreak, but they're not herpetic in nature at all. They are painful and they can develop anywhere in the oral cavity. Well, how do we know which one is which? Location is going to be an important indicator as well as size. Usually these ulcers are minor aphthous ulcers. They can be treated with topical corticosteroids and anti-inflammatories. Usually they're just going to run their course. There are some medicines that we can use to coat that lesion temporarily to make it easier for patients to eat. And topical anesthetics can also provide some temporary relief, but they're really self-limiting, and usually people do have these repetitively and they just kind of get used to them. Remember when we were talking about a true drug allergy and I said hives are an indication of an immune response? Well, urticaria is the medical term for itchy hives. If you really want to impress your professors, use the term urticaria instead of hives on your medical history if your patient reports itchy hives as a allergic reaction. With urticaria, we would see a well-demarcated edema and erythema, and itching is likely. Angioedema refers to diffuse swelling that is not accompanied by itching. Both of these are indications of a hypersensitivity reaction, but they are self-limiting. They can result from stress or anxiety or fear when our bodies are in a heightened state. We're going to talk about a couple of conditions that are autoimmune conditions, the first one being erythema multiforme. This is a severe reaction to an infection or a drug, and it's going to lead to crusting and bleeding lips, but there's not going to be any gingival involvement. We could see bull's eye lesions on the lips, and the patient may have an accompanying fever, headache, cough, sore throat. The treatment for erythema multiforme involves systemic corticosteroids and removing the causative agent. And then we have Stevens-Johnson syndrome. Stevens-Johnson syndrome it used to be called an extreme form of erythema multiforme. So your national board may also associate this with a bullseye lesion, but that's not really correct because Stevens-Johnson syndrome is the result of a prolonged drug interaction, and it results in more extensive crusting and bleeding. The patient may have lesions on the genitalia and the eyes may be involved. And again, the treatment is going to involve removing the causative drug, providing IV hydration, and corticosteroid therapy. Stevens-Johnson syndrome does have a fatality rate of 5%, so it can get very, very severe. Lichen planus is another benign autoimmune condition that affects the oral mucosa, and there are 3 types of lichen planus. Reticular lichen planus is the most common. This results in a lace-like pattern. The condition was recognized by Louis Frederick Wickham. Hence, these lesions are called Wickham's striae. This is a big board alert. Wickham's striae is associated with lichen planus. Lichen planus, Wickham's striae. Wickham's striae, lichen planus. Get that one in your head. The second one is going to be erosive lichen planus. It's less common, but it's a little bit more severe, so it can result in erosions, bulla, or ulcers. And then we have desquamative gingivitis, which is a bullous lichen planus presented in the gingiva. This is a very severe condition where the epithelium separates from the connective tissue. We see desquamative gingivitis in several conditions, which we're going to discuss in just a little bit. Lichen planus is a chronic disease, and it's treated with topical corticosteroids. The lace-like webbing appearance is an important distinction to help you not confuse this with linea alba. On your clinical board exam, you're going to be responsible for recognizing conditions that require referral. So if a condition is inflammatory in nature, a referral is warranted. If it's self-limiting and not associated with inflammation, it does not require a referral. Therefore, lichen planus would need a referral, whereas linea alba would not. So you definitely don't want to get this one confused with linea alba. Reiter syndrome is a reactive arthritis that results from infection. There is a triad of symptoms associated with Reiter syndrome, which are arthritis, urethritis, and conjunctivitis. In the oral cavity, we would see aphthous-like ulcers, erythematous lesions, and sometimes these can be confused with other common lesions like geographic tongue or median rhomboid glossitis. It gets really hard to tell the difference between those two. So at this point, you're probably thinking, Ms. Richardson, these conditions look all the same. How am I going to know the difference? How do I know which condition it is if they all look alike? This is where I would tell you that we must apply the theory of Occam's razor. This is not anything in your textbook. This is just something that I want to point out to you that's important as you move along. Occam's razor is a principle that you need to apply to every aspect of your life, even vaccinations. So think about this with vaccinations. When you're considering your options, you need to look at how many assumptions are necessary for each explanation to be correct. And then, if the explanation requires extra assumptions, you need to demand evidence to substantiate that claim. So, in the case of vaccinations, if you're going to say, well, is it likely that the vaccinations are poison, the government is poisoning us, and they don't do any good, they actually hurt us? Or is it more likely that medical professionals who understand the science of immunity have developed these vaccinations to save lives, and that indeed they do work and the outcome far outweighs the risk? Which one is more likely? So if the explanation that they're poison is less likely, then I need to see a lot of evidence to convince me that it's less that's the way that I'm going to think. So an extraordinary claim is going to require extraordinary evidence. If I have an extraordinary claim that vaccinations have caused autism, then I'm going to have extraordinary evidence to substantiate that claim. And sadly, the physician who scared everybody with that claim lost his medical license because his evidence was very weak, and they have since done many studies which have counteracted that, and it's very clear that the vaccinations are not what are causing autism. There is a lot of hope, though, on the horizon with that in regards to genetics and some things that they're starting to figure out. So I'm hoping in the next 10 years we will have a lot more answers in that regard. So what does Occam's razor really mean? It means that the simplest explanation is the most likely. Is it just a simple aphthous ulcer or something really awful like Reiter syndrome? How much evidence do I need to diagnose Reiter syndrome? Which one is more common? Which one is more likely? Which one is more of a simple explanation? So usually an aphthous ulcer is just an aphthous ulcer. And I can assume that anything other than that is going to require a lot more evidence. So here is your second submission question. What is the name of the theory which suggests that the simplest explanation is most likely correct? Okay, let's get back to some of the conditions that we were talking about. Remember in chapter 1, we were learning about multifocal lesions on radiographs? Well, Langerhans cell disease is a really good example of that. Now, hopefully you're never going to encounter this disease, but what I want you to remember is that soap bubble appearance on radiograph. If you recognize that something is severely wrong, let's make sure that patient gets to the oral surgeon ASAP. In Sjogren's syndrome you have heard about before, but this is an autoimmune disease with microscopic salivary changes. These patients have an increased risk of Raynaud's phenomenon, which causes a decrease in blood flow to the extremities. I've actually had several students who've had Raynaud's phenomenon. Maybe you do. If you do, share it with the class. Let's see it. Raynaud's phenomenon can look really scary, but it's pretty self-limiting. The appearance of Sjogren's syndrome, the patient basically will present with dry eyes, a very dry mouth. For us in dentistry, we're very concerned about these patients who have chronic xerostomia because of the increased risk for decay. The treatment involves providing the patient with saliva substitutes, and the prognosis is that it's chronic but benign. They are at risk of developing other disorders, though, so usually they are closely monitored by their physician. Lupus erythematosus. This is also a board alert. Lupus has a characteristic butterfly rash that appears across the face. This is an autoimmune disease. These patients, with lupus, it affects many different organ systems, and different patients are affected in different ways. But some of the oral lesions that we may see would be erythematous plaques or erosions, maybe white striations radiating from the center of a lesion. The treatment is going to be anti-inflammatory and immunosuppressant drugs. And as you can tell in this chapter, nearly everything we're talking about, the treatment is some type of immunosuppressant, some type of corticosteroid or topical steroid, something to suppress that immune response. The prognosis for lupus, it can range anywhere from very mild, but it can be very severe and it can result in death. Pemphigus vulgaris. Pemphigus vulgaris is a severe progressive autoimmune disease that affects the skin and the mucous membranes. It's going to appear with shallow ulcers, vesicles, and bulla. Here is another board alert. Pemphigus vulgaris has a characteristic sign called Nikolsky's sign. Nikolsky's sign is a sign where if you were to take your finger and rub that gingiva, then the layer that you have rubbed will slough off, will just come right off. The treatment for pemphigus vulgaris is high-dose systemic corticosteroids. The prognosis is generally fair with the corticosteroids. However, long-term use of corticosteroids can lead to adrenal suppression and susceptibility to infection, osteoporosis, kidney problems, eye problems. I mean, the list goes on and on. With corticosteroids, that is such a great drug, but it also comes with a high price. It does affect our organ systems over time. Beckett's syndrome is a chronic, recurrent, and multi-system autoimmune disease that's caused by an abnormal immune response triggered by infection or environmental antigens. Oral ulcers are present in 91 to 100% of these patients. These are painful ulcers, which again mimic a minor aphthous ulcer. The treatment for this would be systemic and topical steroids. It is a lifelong disorder, and they do go into remissions and exacerbations. There sometimes is CNS involvement, and that may include paralysis and dementia. When the CNS is involved, that generally has a poorer prognosis. Desquamative gingivitis is a term describing a shedding of the tissue. So anytime you see desquamative, that's going to mean shedding. There are several conditions that we see this, such as lichen planus, mucous membrane pemphigoid, pemphigus vulgaris, lupus. So it's more of a descriptive term than an autoimmune disease itself. With immunodeficiency, we can have primary or secondary immunodeficiency. We've talked a lot about immunodeficiency in chapters 2 and 3, and there are two ways that we can develop immunodeficiency: primary, secondary. Primary deficiency results from genetic or developmental issues, and secondary results from an underlying disorder. Secondary is much more common. We're going to see this with corticosteroid therapy and other immunosuppressant therapies. You can see this with malnutrition or an infection that involves the immune system like HIV. That's going to be it for Chapter 3, guys. In Chapter 4, we're going to discuss infectious diseases, some of which you've probably heard of before. Don't forget to, like my video, and please email me if you have any questions.